let us move to the next one. To chair the session, may I request Dr. Rakesh Jadhav and Dr. Suchit Majumder to come in as chairpersons and to speak on the subject bundle branch block in ECG. Actually, the original title I kept it when one should be cautious, but Dr. Narsimhan wanted to have a little different title, so it is up to him. Dr. Narsimhan, please go ahead with your deliberation.
Thank you, Dr. Guha. And I think Dr. Narsimha is our teacher, and he's a teacher of everybody. He teaches what we try to preach and what we try to practice. And this is a very important topic because invariably you find bundle branch block on ECG. So to know what significance of bundle branch block is, when to pace, when to ignore, when to go for further investigation, I think none other than Dr. Narsimhan can explain in the best possible way. Dr. Narsimhan, sir, please.
Thank you very much, Dr. Yadav and Dr. Guha. I've kept this talk a little more basic and clinically oriented, so pardon me if some of the concepts are very basic. As you all know, the initial vector in a right bundle branch block, this is the sternum, this is the vertebra, and in all of us, the activation is from left to right of the septum, which inscribes a small r, and then a very delayed activation of the right ventricle leads on to the R prime, which is very tall and delayed. So that defines the right bundle branch block in terms of electrophysiological characteristics. However, the biggest problem is in several patients, it can be a normal finding. Also, it is a marker of structural heart disease like hypertensive heart disease, coronary disease, and especially pulmonary disorders. So even though by itself, it may not indicate a need for a pacemaker, it will tell you that you need to investigate this patient further. For example, for diastolic heart failure, for hypertensive heart disease, there is some diffuse interstitial fibrosis that is going on that preferentially affects either the conduction system in terms of fibrosis or calcification, intravascular calcification. So you need to take a little more holistic view about this in terms of treating the patient. For example, these things are very common in people where the calcium phosphorus ratios are abnormal in renal failure. Extrinsic calcium can cause the problem. So when you have a person with a bundle branch block and syncope, very often it's neurocardiogenic syncope versus is it a true arrhythmic syncope is the question. Here, more than the ECG, you go by history. An abrupt onset of syncope, absence of prodrome in a person above 50 with bundle branch block, we tend to err on the side of giving a pacemaker because very often tilt test may be falsely positive and an EP study may not be able to throw some light on this. However, there are certain clinical characteristics. For example, if you see a QRBB, that tells you that the patient has a septal fibrosis. It may be an old infarct or a dilated cardiomyopathy or a HCM, which may be causing, and you have a lower threshold for giving a device. However, if a patient in addition has poor tissue velocities in this situation on echo, it could still be not a bradycardic syncope, but a VT could be a reason for the syncope in these patients. The second is when you see a patient with syncope and he comes to with a sinus tachycardia and he has a right bundle branch block, one of the causes which presents as syncope and right bundle branch block is an acute pulmonary embolism, which presents typically with an S1, Q3, T3 and a sinus tachycardia. You falsely see a small transient AV block and start working up the patient for a pacemaker. You may miss the underlying diagnosis in these patients. Third is not all right bundle branch block are always related to conduction system disease. The clue is the amount of delay and slurring that you see in R prime. As I told you, the second half of the QRS, which is the R prime, is a delayed activation of the right bundle. If it is very diminutive in voltage, if the voltage of the second component is very diminutive, it suggests a diffuse muscle disease of the right ventricle, and ARVC should be considered in these patients as a delayed epsilon wave masquerading as a bundle branch block. This is typically the pattern. Instead of a sharp upstroke, a very delayed and a diminutive R prime. So in contrast to a typical right bundle branch block where the delayed component is tall and robust in its voltage, patients with ARVC will have a very diminutive R prime and much more delayed than normal. The other condition is the company it keeps. When you have a person with a right bundle branch block and the PR is also prolonged, you need to think whether there is some diffuse conduction system disease or something else going on. If the voltages are all tall, one of the differential diagnoses is a forme fruste of HCM. But if you start seeing this kind of Q waves, spiky Q waves all over, HCM is a differential, coronary artery disease is a differential, and patchy fibrosis due to granulomatous disorders like sarcoid should be considered. The reason why this is important is because just giving a pacemaker alone may not suffice, because giving a pacemaker 2 years later, he'll come as a dilated cardiomyopathy because of a progression of underlying disease in these patients. Similarly, when you have a diminutive voltage of the R prime, which is accompanied by vesicular blocks, it again draws your attention to a condition like sarcoidosis or a tuberculous myocarditis, when you have a diminutive R prime component with vesicular block or prolonged PR interval. So not only is pacemaker required, but you need to work up these patients for an additional disease beyond just giving a pacemaker to a patient. The third condition, which can again present as right bundle branch block, is conditions like Brugada syndrome, where the typical ST elevation can be masked when they develop a right bundle branch block. The clue to the diagnosis is the base of the triangle of the R prime is very broad. That is, if you take the R prime, the second component, it is a very broad, slurred, and therefore the base will be very wide in comparison to a typical incomplete right bundle branch block where there is a spiky R prime. This should make you suspect that it is probably Brugada, and you need to move the ECG V1 one space up to confirm the diagnosis if necessary with pharmacological challenge. And again, the right bundle branch block like pattern may indicate this kind of a typical notching that is seen in inferior leads, which should serve as a marker for underlying left to right shunt, especially at the atrial level. We have had this kind of situation where patients come with right bundle branch block and they mistake this as tachycardia, and repeated cardiac shocks are delivered. Remember, large anterior MI in a young person immediately can trigger a surge of adrenergic response, and they have a marked tachycardic response compared to older people. And therefore, this is typically a young smoker with large anterior MI coming with a heart rate of 150 and 160. And the clue is to look at one particular lead anywhere where you see a P followed by a QRS, P followed by a QRS. And if this is accompanied by an ST elevation in AVR, this may suggest a left main occlusion, which should not be mistaken as VT, because this patient very often are coming to casualty with very rapid tachycardias and repeated shocks, and amiodarone is started, missing the underlying diagnosis in these patients. Sorry. Now, when you have a patient with a right bundle branch block and comes to you with syncope, when do you decide that this is malignant or which requires a pacemaker vis-a-vis a benign right bundle branch block? One is if the PR is prolonged or even upper limit of normal in such a patient, or if they have a posterior fascicular block. Posterior fascicle seldom gets involved in conduction system disease, unless it's a diffuse conduction system disease. And very often these people will progress to develop complete AV block, and we will have a lower threshold for giving a pacemaker for these patients. Again, when you sit in the casualty and the patient comes to you with hypotension and comatose situation, and it looks like a right bundle branch block with delayed second component and notching, and there is a delayed second component in AVR, one of the differentials is something like a diffuse sodium channel blockade. Several drugs we use in clinical practice like amitriptyline, tryptomer, tricyclics. Of late, we have been seeing cocaine, which is young adults coming with cocaine poisoning, can present with altered sensorium and a right bundle branch block like pattern. You should consider this because immediately you need to start them on sodium bicarbonate, which will normalize some of the hemodynamic abnormalities before giving any other ionotropes to these patients. Switching gears to left bundle branch block. As I said earlier, the initial activation in all of us is through the left bundle and a left to right activation that gets disrupted in patients with a left bundle branch block, especially if the left bundle branch block is accompanied by left anterior fascicular block. So the sequence of activation will be from the right side of the septum, this aspect of the septum where the posterior papillary muscle is inserted. So you will have a posterior papillary muscle contracting with the septum and a very delayed lateral wall activation and an eccentric contraction of the lateral papillary muscle leading on to eccentric mitral regurgitation in some of these patients. So left bundle branch block can be a relatively asymptomatic finding in a person with hypertension and LVH, but can lead on to progressive ventricular dysfunction or present as syncope. Again, the typical criteria is 120 milliseconds or more, and we typically look for a notching or a slurred R wave in V5 and V6, and the R peak time is prolonged. Why is this relevant? Because if you look at it, the transeptal activation time, you're seeing the sternum, the interventricular septum, the right bundle gets activated first. From the right to the left, it takes about 40 milliseconds, and another 40 milliseconds, the whole of endocardium gets activated. Then the second notch is predominantly because of a late activation of the epicardium. Now, why is this relevant in terms of looking at an ECG and deciding whether a patient is going to respond to conduction system pacing or you need an additional left ventricular lead? This is what the ECG should tell you. The initial component is sharp, which is due to endocardial activation of the left ventricle. The delayed component is because of the epicardial activation of the left ventricle. The taller and the broader and more notched the second component, it suggests that it's probably better to put a left ventricular lead rather than correcting it by just fixing a lead in left bundle itself. So the second component, the height and the width, tells you the amount of muscle that you are likely to recruit by placing an LV lead, and therefore this patient is likely to respond very well if the second component is tall and fat. Now, again, it makes a lot of difference to understand whether this bundle branch block is rate related. And physiologically, all of us know with a transition from a particular heart rate to a faster rate, the bundle branches can physiologically block. If it is right bundle in long term, it doesn't seem to have much of a prognostic implication. But patients with a left bundle branch block, which develops during tachycardia, can develop a syndrome similar to angina. And this is called a painful left bundle branch syndrome, where they present exactly with typical angina because of a delayed epicardial squeeze of the epicardial vessels. And they truly have lateral wall ischemia in this situation, which is functional, and they can be corrected by left ventricular free wall pacing. In contrast to that, if you have a patient where the QRS is narrow, but when the heart rate decelerates, you get a very wide QRS. This is malignant, this is pathological, and this indicates phase 4 block, and phase 4 block usually happens in a diseased bundle branch, And if you see this in a person with syncope, you will have a very low threshold for giving a pacemaker for that patient. The other thing which we forget is when you have a person with a pre-excitation and a left bundle branch block like pattern, if it's a pure pre-excitation, the right-sided pre-excitation itself can cause some LV dysfunction. Getting rid of this pathway may correct the ventricular dysfunction as well as you may be able to correct the QRS. However, one of the subsets, some of the hypertrophic cardiomyopathy variant like AMP kinase mutate, PRKAG mutations can present with this kind of a syndrome where they will have a pre-excitation and a very tall QRS in lateral leads, and you should carefully look at the echo before just jumping and doing an ablation on these patients. When you are uncertain, when the patient's history is uncertain, when you are not sure what to do, you can, a very rare situation, you may consider doing a his bundle study in them. If you demonstrate a very prominent HV prolongation, which worsens with pacing or gets blocked, you may consider giving a pacemaker for a given patient. So the EP study is restricted to an occasional situation when you're not able to decide clinically what is required as a next step. Switching gears, among patients with left bundle branch block, it becomes because the initial vector in the septal activation is altered. There is a difficulty in diagnosing acute MI, and Scarbosa criteria would be useful to make a diagnosis. This is a typical example where the patient has an ST elevation in the lateral leads in the presence of a left bundle branch block, and patients has atrial fibrillation, and this patient should be immediately either taken to cath lab or they need thrombolysis. And it's important in late presentation, some of these patients, the old infarct can be picked up by looking at the notching in the lateral leads or mid precordial leads. If there's a lot of fractionation and notching, that should make you suspect there is an old septal scar in those patients. Second is, if you look at the ST to S ratio, that is, in a person with a chronic left bundle branch block due to conduction system disease, the ST elevation is very minimal compared to the depth of the S wave. In a person with an acute MI, however, the ST elevation is much more in comparison to the S wave depth. So you look at what is known as S to T ratio, and if that is more than 1/4 ST elevation, then it's more likely to be an acute ST elevation MI, and you need to consider as such if this patient has an acute coronary syndrome. Occasionally, you have this kind of bundle branch block-like pattern, but this is not a typical bundle branch block. When you see an effacement of the ST segment in a person with a bundle branch block-like pattern, it should make you suspect a diffuse sodium channel blockade. And the commonest sodium channel blockade that you see in clinical practice is hyperkalemia. Hyperkalemia at very high levels blocks all the sodium channels, and therefore there is a QRS becomes very wide in these patients and presents like a sinoventricular conduction like this patient. And again, when you have these patients with bundle branch block, you need to be extremely careful when you take them for even minor central vein insertion or pulmonary cath insertion, because transient trauma to the existing right bundle can result. This is during a right heart cath in a person with a bundle branch block. The catheter-induced complete CHP can occur. You should be aware of this complication. If you have a person with syncope, and if you have in the same ECG, one showing a left bundle and right bundle, you don't need further testing for this person. Straight away, go ahead with a pacemaker. And this is alternating bundle branch block. The third situation where physicians need to be aware is when you have a person with what looks like a right bundle branch block, but the S waves are absent in 1 and AVL. That should make you suspect he has a bilateral bundle branch block called as masquerading right bundle branch block. These patients are likely to benefit from CRT as much as a pure left bundle branch block. I think I've given just an overview of this. I would like to stop here. By any means, this is not complete. If there are any questions, we'll be happy to handle at the end of it. Thank you so much.
Thank you, sir, for a wonderful talk. Dr. Narsimha, this is a very common query that we find an RBB with PR interval of 180 millisecond. And these patients are often refused for any general surgery. In pre-anesthetic checkup, the surgeon will, the anesthetic will say, it is a high risk, get an Holter done. Some say put a temporary pacemaker while doing surgery. So, and patient is entirely asymptomatic. So what your take-home message for these type of patients? Because it's a very common scenario.
Nothing is required. Nothing is required. As I said, if a person is asymptomatic, normal effort tolerance, we can clear them for surgery without any issues.
Second important query, can you tell me which patient of left bundle branch block need further investigation? Asymptomatic 50 years female came with a left bundle branch block. So just tell 4 or 5 points for an audience that these patients, if these are the things, they required further investigation.
Okay. Left bundle branch block initially usually suggests there is some other disease we are missing. At least listen to the patient carefully, look for effort tolerance, look for murmurs, because the commonest reason for that in an asymptomatic person is annular calcification. So either aortic or mitral annular calcium, which starts very as a speck of calcium at the age of 55, 60 in a postmenopausal women, will progress to complete heavy block over 2 decades. So you look for any cause for which will aggravate the calcification. One of the commonest thing is uncontrolled hypertension, hyperuricemia, several other things which can be corrected. So it gives an opportunity to evaluate the patient for aortic stenosis, mitral regurgitation. And of course, if the effort tolerance is limited, you need to think of coronary evaluation. But having said that, the commonest cause in women is uncontrolled hypertension.
Sir, can I ask one question to you?
Sure, please.
Yeah. So how will you evaluate a patient who has a transient LBUB while doing a TMT? Means how will
It's
you
a very, very
satisfy that
interesting
patient?
question. Because if you take a ventricle and acutely load the ventricle, you, for example, go and avulse the aortic valve and the ventricle dilates, animals will develop bundle branch block. So there are 2 reasons for bundle branch block happening during exertion. One is long refractory period of the bundle branches, or there is a transient ballooning or dilatation of the ventricle during TMT. So the second cause is more important and malignant. You should suspect a triple vessel disease in those patients. If a patient is symptomatic and he has developed other changes, you should rule out a triple vessel disease. However, the other cause is, of course, asymptomatic progression of an incomplete left bundle branch block, which becomes complete during a sinus tachycardia.
So does the rate is important, or that means at what rate he develops an LBUB? That may be important in that case.
Yes.
So if he develops at maybe 130 or something, may not be
Yes.
that important as one develops at 80 or 90.
That's right. As you know, the bundle branch block occurs at a higher rate, but resolves at a lower rate. That is, you will develop occurrence of a left bundle branch block at a rate of 150. But it has to wait till the rate comes to 110 before the block resolves because of functional re-entry into the contralateral bundle.
May I have a quick question?
Yes, please.
How do you use a beta blocker or diltiazem in presence of different bundle branch block, second degree and bifascicular block, etc. in these scenarios?
That's a very, very important question. So if you have a person with bundle branch block and normal PR interval in an asymptomatic patient who has got, say, for example, a mild LV dysfunction or hypertension, there is generally no fear of using a beta blocker, because if you actually reduce the sinus rate, the His-Purkinje system will conduct better. On the other hand, if you think the patient has a bundle branch block plus an AV nodal block, which is marked by a little prolongation of the PR interval, then I would be cautious about using a beta blocker in those patients, especially if they had symptoms.
Thank you, sir.
Dr. Narsimhan, there is a question in the chat box. Any
Yes.
comments on Barcelona criteria?
I'm not aware of this.
I'm also not aware of. That's why I just asked you.
And
This
thank
is
you
there
for
in
the
the chat
question.
box.
That helps us to go back and read. Thank you so much.
One more question. Actually, sir has
Please.
already mentioned that the role of EP study when you should do. So how many means we can see a percentage of patients if we put an empirical pacemaker in a bundle branch block, there is a chance of recurrence of syncope in those patients. Maybe that is around 20 to 25%. So what is your take, sir, on ILR in those patients?
I think ILR is far overrated by the studies. If you really look at it, any ILR, yes, it picks up AFib, it picks up transient AV block, but as a clinician, I'm interested whether the event rates at the end of, suppose you randomize 1,000 patients, have I improved the survival, prevented syncope? Then it becomes very questionable, because the next time the patient comes to you, he may be, ILR will pick up a VF, but the patient is dead. So when you need to have a certain degree, if it's a strong suspicion, it's a traumatic syncope, patient had an abrupt fall, I don't wait for an ILR, I just go ahead and give them a pacemaker.
Thank you, sir.
Thank you. Thank you very much.